challenging time. To be at your home in front of your computer with us, we're so grateful for. And I also want to just say a special thank you to the Heiress Foundation for creating this platform today for us to talk about breast reconstruction while we are in an incredibly unprecedented chapter. I'd like to introduce myself first. My name is Melissa Berry, and I'm the founder of cancerfashionista.com. And it's a beauty and fashion resource for women that are thriving through breast cancer and beyond. And I'd also like to introduce Dr. Jonathan Bank. He's a board-certified plastic surgeon and breast reconstruction specialist. He has an expertise in reconstructive surgery after mastectomy. So the focus of our conversation today will be on issues and concerns relative to
Thank you to the Heiress Foundation. I know it's a difficult time, and sometimes I feel like breast reconstruction is the last thing we should be talking about, but on top of whatever is going on in the world, I can't imagine dealing with that plus the prospects of breast cancer and the ramifications of that right now. So
exactly. And that's why I think it's so great that we're having this conversation, because I think breast cancer and breast reconstruction can be so challenging in a normal world, but now we have a whole other layer that we're dealing with. So thank you again for having this conversation with us. So I'll kind of jump right in. How has the coronavirus affected your role as a physician?
Well, it essentially stopped what I've been doing as a plastic surgeon, as a breast reconstruction plastic surgeon. We are essentially on pause for all new cancers and any subsequent stages of reconstruction that were planned. And this was put into effect a week or two ago and has been rolled out, I would say, in several stages, depending on the location in the country. And we're based in New York, obviously being hit quite hard. And for a couple of weeks now, we've essentially been on hold. We've been preparing for that prospect for several weeks, anticipating that we may have to stop operating or may stop having to do the surgeries that were planned, and have adjusted some of our procedures in order to accommodate, with the obvious goal being is to, first of all, do no harm to patients, not expose them, staff, and families to just being in the hospital, being around patients with COVID-19. So the first goal is to just do no harm, and then later address once things are safe to go ahead.
Exactly. Well, thank you for giving this extra layer of protection to our community, really, because it is obviously much needed. Sort of as a layer onto that, what advice are you giving to patients when you're informing them that they need to put their reconstructive surgery on hold? That's got to be a difficult conversation to have. So, how do you deliver that information? What has their response been? And, what kind of advice can you share with them and everyone else that's tuning in today?
All right. It really depends on the stage in which the patient is in. I would say that the hardest conversations by far have been ones with women that were recently diagnosed, had their mammogram, or were diagnosed on physical exam and subsequent biopsies in the days or weeks leading up to this pause. So, and they may have been scheduled to have consultations for a mastectomy or a lumpectomy and various types of reconstruction, and essentially enter your office, you start discussing a plan, and then later that day or a day later, you're having to just renege on all that and say, oh, that's true, but it's on hold right now. So that's been very, very difficult. And then we try to understand, well, what is an option at this point? So it really has been dependent on the patient's situation and type of disease that they have. Again, I'm not a breast cancer specialist. I deal with the reconstruction and therefore deal with a lot of the disease itself. So in patients that have other options, such as radiation or chemotherapy or hormonal therapy, that is something that the cancer centers have been advocating. and the extirpative surgery or removing of the tumor is scheduled to be done at a later date. Now, there's still parts of the country where surgery to excise cancer is still permitted.
Mm-hmm.
And I can't speak for those areas, but
Right.
I know that's still happening. But across the board, across the country, the American Society of Plastic Surgeons has essentially stated that reconstructive surgeries at this time are considered elective. There are, of course, nuanced situations and particular instances where certain types of surgery will be permitted and
Mm-hmm.
performed, but not in my part of the country, unfortunately.
Right. And so, what have the responses been from your patients? Are they, for the most part, at ease and understanding of the whole thing, or do you have some patients that are really, extremely frustrated and upset, or is it like a mixed bag?
I don't think anybody's at ease these days, but
Mhm.
nobody's really been combative. Everybody's quite aware and understanding of the situation. I'd say women that were planning, say, prophylactic mastectomies were happy to sort of give up their spot in favor of women that
Oh
have
wow, that's wonderful. Hmm.
mastectomies for cancer or piping
Hmm.
cancer. And so everybody's sort of chipping in their way, I suppose. Um, it's just sad across the board, but the initial instinct of everyone is everybody's been understanding and say, okay, what are my options now? I'm just looking forward. I'm sure some people take it harder than others. So.
Of course, especially I think, myself having had breast cancer and reconstruction, you have like this plan and this path, and it's like you want to go through it as quickly as you can. So then when you have a roadblock like this, it could be, it could create a lot of anxiety. But at the same time, I'm sure there are many of us or all of us that don't want to, go to a hospital right now. Number one, to put themselves at risk for infection or, contracting the coronavirus. We're putting any additional layer of work on the current hospital staff, which is currently so overtaxed at this time.
Right, life throws you a curveball. You have to figure out how to deal with it.
Exactly.
I would say that this is and we've been doing a lot of this, a good opportunity for people that have questions to ask them, and there are other ways of doing that. We've been invoking telemedicine platforms, just having phone conversations with patients, and it's a good opportunity for us that may not be on the front lines of dealing with COVID to still be able to be a doctor one way and remain in contact with our patients. I'm sure at some point we'll all get called up to um, to chip out, to chip in rather,
Right.
and until that comes, we're going to practice what we can with patient education and discussions like this that may help alleviate some of the anxiety.
Yes, and thank you again for joining us, because I know I received so many questions. The Heirs Foundation did too, and I just want to let the audience know that's listening now. If you guys would like to ask any questions, we'll do our best to answer them. That's why we're having this. We want it to be sort of like a fireside chat where we can all come together and answer questions and put your minds at ease as to the best of our capabilities. The other question I had, Dr. Bank, is how are you currently handling patients who just had their reconstructive surgery? So they may have drains in and they're really, dealing with things that are pretty raw. How are you navigating those patient cases?
Sure, that doesn't stop. We're still doctors, and we're going to still take care of patients that have issues that need to be addressed, whether it's removing drains, dealing with wounds, infections. All those are considered emergencies. And if God forbid somebody does need surgery, then that's permitted. It's with the discussion with the hospital. That's definitely that's an imminent threat to life, say, so we can definitely address that. So our office is still open on a very minimized scale. We see patients, we screen them for the expected symptoms of COVID, take their temperatures, and then usually would see them with appropriate protective equipment. Luckily, we geared up before this started, so we have appropriate masks, gloves, gowns for the staff and for the patients. So that's definitely not stopping. And some situations that may not absolutely mandate a face-to-face, or maybe there might be questions that can be answered on remote platforms, then we do that as well, and then sort of triage them before a face-to-face encounter.
Great. So you're really able to interact with them, even if you're not seeing them in the office, you're able to sort of help them get the help that they need based on a case-by-case basis.
Absolutely.
What would you say your patients are needing of you these days when they're reaching out to you? Is it emotional support? Is it, that they have issues with their reconstruction? What would you say is the issue that you're dealing with most lately, especially this past week or two?
It changed over time. Obviously, the further back, it was more patients that have recently had surgery in the preceding weeks or two. And then it was just, again, managing the post-operative care. At this point, it's, okay, I know everything's on hold. I still have a question about this or that. Is it normal to feel one way or the other? Can I just check in with you by FaceTime or our telemedicine platform? And it's actually been an opportunity for patients that may not have an acute issue, may have had components of their reconstruction or reconstruction before, and have ongoing questions. Everybody's for the most part at home, and their mind wanders. So we've been doing some actually fresh consultations about all kinds of matters remotely. So
wonderful. That's amazing. And is there any extra precaution that you're asking your patients to exercise in addition to everything else that the general public is doing?
Well, I'm telling my family that the most important thing that one can do for themselves at this point is to stay as healthy as you can be, work out in whatever capacity you can. I don't think that that's very different for the breast cancer population, except for the typical physical therapy or whatever physical therapy activities one can do at home to just avoid having complications of reconstruction that relate to the musculoskeletal system. So a lot of women will have chest tightness that can end up causing them to be afraid to move other components of their upper torso or lower torso if they had a flap operation, for instance. So I would say, this is a good time to just continue stretching, continue core exercises at a low-key fashion. It's unlikely that you're gonna, as opposed to going out for a jog, that I would probably not advise right now.
Right.
If you trip and fall and you end up in a hospital for
so right, like it sounds like the moral of the story is don't get too courageous with your exercise routine right now.
Play it safe, but don't stop.
Right, like still important to move, especially in quarantine. I think even for the average American, it's it's definitely more challenging to, because we're not going to the gym. There's all these other alternatives. So it's I think it's important probably for everyone to move, but not, like you're saying, just take some extra precaution.
Yeah, plenty of exercises or specific for breast reconstruction patients that physical therapists put out that we could later link to if you would like.
Excellent. That'd be great. So we have some questions coming in. This one is from Michelle. What are your thoughts, Dr. Bank, on a nipple sparing procedure since reconstruction is probably 3 to 4 months away?
So the question is, would one plan to do a nipple sparing procedure at this point, meaning a mastectomy at this point in a nipple sparing fashion with a reconstruction later on? That's a tricky one, and that's been quite a point of debate, especially early on when there was a question, what can surgeons do, what can plastic surgeons do? Would they recommend performing a mastectomy now without even starting a reconstruction? versus a smaller procedure, say just a lumpectomy, and then maybe completing a mastectomy later on. So the issue is, if one does a mastectomy without an immediate reconstruction, there's a chance that the skin envelope, meaning the breast skin and nipple, will contract and scar down to the chest wall if there's no spacer in between. So if a mastectomy is performed, it's like emptying a sack. The sack just collapses down. There's nothing to keep the skin stretched out and pliable. That's one of the advantages of doing an immediate reconstruction, whether that be in stages with a tissue expander, or implant reconstruction, or with a flap. Now, it's not to say that it's impossible to do a quality aesthetic reconstruction with the skin envelope being deflated and potentially scarred down with time, but it's probably not as optimal as doing it in an immediate fashion.
Okay.
So it's a dilemma.
So it's not it's not like there's no like clear, easy, it sounds like it may depend on each case.
Yeah, but I would say that if a lumpectomy to remove cancer is an option, I would recommend performing that and then getting the cancer out of the way.
Right.
And then if any additional treatment is required, radiation or chemotherapy, I would use that, and then at a later stage complete the mastectomy. So you have then the option of performing an immediate reconstruction, but you've bought yourself a whole lot of time to not suffer the consequences of not having an immediate reconstruction. And I've done that procedure in a planned fashion before COVID times, where for whatever reason the patient couldn't have a mastectomy. Let's say they were a smoker, or we were planning to do a nipple sparing procedure, but the nipples the nipples were too low or the breasts were too large. So we'll frequently do an intermediate step where we'll do a breast lift or a breast reduction, remove the tumor at the time of the reduction. So it's kind of combining a breast reduction with a lumpectomy. That's called an oncoplasty. You're combining the oncological portion and the plastic portion, so the oncoplasty.
Right.
And then you're able to position the nipple and the areola complex in a favorable position on the breast mound. And then at a later stage, once everything's healed, you can then perform mastectomy with immediate reconstruction without having to worry so much about moving the nipple areola complex at that time. So it makes the second operation more reliable versus some other techniques in which you would choose a different pathway.
Thank you for that explanation, although I know it's not a totally clean-cut situation. But Michelle, we hope that we answered your question and helped you with that decision. We have another question coming in from Tanya. She asks, I am finishing up chemotherapy just after Easter. I am concerned because I do believe my doctor is planning mastectomy, and I was planning on immediate reconstruction. How long can I wait after the end of chemotherapy for surgery? I am HER2 positive.
Is there more to that question, or I can't see it's right?
It may have gotten cut off a little bit.
So typically we wait approximately 1 month to 6 weeks from the completion of chemotherapy until any other surgery is done. The reason being, we believe that it takes that much time, more or less, for the chemotherapy to be out of one system. And what chemotherapy does, it basically, there are different types, but the basic premise is that they prevent tissues from replicating, or cells from replicating, and that's how they stop the cancer cells from growing. Now, we need tissue healing and tissue replication, or cell replication, for healing purposes. So that's why we kind of want to wait until the chemotherapy that could prevent or inhibit wound healing, we want that out of one system, and that's where that waiting period comes from. Sort of common practice to wait approximately a month. On certain occasions, you can wait a little bit a shorter duration of time. You can definitely wait longer from a healing perspective. Then it becomes a question, let's say you cannot operate, what's the window in which you should operate from an oncology standpoint, which again, I can't truly answer. I would say it depends on the stage of one's disease, early stages.
And Dr. Bank, I'm sorry to interrupt, but we did get the rest. I did get clarity on this question. Tanya does have lymph node metastasis, so I don't know if that has any bearing on your answer.
Yeah, so that would indicate that Tanya probably has a stage 2 disease at least, and the neoadjuvant chemotherapy is probably the most critical component. The fact that she's HER2 positive. Again, I shouldn't be answering these
questions. Right. Yeah, we do want to preface this by saying, your focus is definitely, your expertise is breast reconstruction, but we can tread lightly on some of those topics.
So, being HER2 positive, she does have an option of receiving Herceptin unless there are contraindications. We can actually operate with patients that are taking Herceptin because that doesn't interfere with cellular replication like the chemotherapy does. So you'll probably be on Herceptin for at least a year if that's what's prescribed, and then it's okay to operate on that. Now the whole question becomes, where is she in the country? How aggressive the disease? What particular recommendations are there in her part of the world to operate or not? So at the very least, I would hope that they would offer some kind of removal of the tumor.
Right.
Not she's in a she's in a better situation because she has received chemotherapy, so they're sort of at bay.
She's further along in the process of in the scheme of things.
Right. Perhaps radiation therapy is an option, and then the Herceptin is another option. So she has other options to hold things for the time being if surgery is not.
Thank you for answering Tanya's question. And Tanya, we hope that we helped answer your dilemma there. The next question, and thank you, Dr. Bank, for answering. The next question it's actually 2 parts. So how far out are you still immunocompromised after having cancer? And the second part is, I'm almost 3 years out after having breast cancer and bilateral mastectomy, chemo, and deep flap reconstruction. So the first part is, how far out are you still immunocompromised after having cancer?
Another excellent question for the oncologist.
Yes.
As a doctor, I can say, I would say it's a period of several months, and everybody's a little bit different in how they respond to the chemotherapy. Depending on the chemotherapy, it can affect the white blood cell count, which is are the cells that provide the immunity, or a component in what provides immunity to people. If the chemotherapy severely affected their white counts, and particularly a subset within the white blood cell count, that would be a good indicator for if the immunity is resumed to a baseline, and that can be done essentially with a blood test as a general indicator. Once that's back to normal, I would say that most people would consider one somewhat immune competent. Of course, we don't know everything, and that's one blood test, and you can't presume from that we know everything about one's immunity. But I'd say once that's back to normal, and that can vary between days and months. I would say at 3 years, I would probably consider yourself a competent immune host, provided that there are no other sort of surprises.
Sure.
That
makes sense. Thank you for that answer. This next one is definitely more specific to reconstruction. So this is a question that we actually received yesterday in advance of the Facebook Live. This patient asked, I did a double mastectomy in December and have expanders, and my exchange will be possibly in July. Should I still go forward with it or cancel my surgery because of the coronavirus?
Mm-hmm. If you're booked that far out, I would not go ahead and cancel it. If the hospital system in which you're scheduled to have your surgery feels that it would be unsafe to do the surgery, then they're going to go ahead and cancel that for you. I would try to keep my place in line and 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 not change that at this point, with the understanding that hopefully by then we'll be back to normal activity, but there will be a backlog of cases, cancer diagnoses that, as a fellow human being, I would say capitulate and let somebody that has something that's more urgent go first. I wouldn't cancel it for now. I think you're totally fine to have tissue expanders in for almost any period of time. They're definitely not as comfortable as the final implants, but there's no problem in waiting that long or even longer. I've seen patients that have had tissue expanders in for years. They just
Yeah, I was going to ask you, I mean, as a general rule, like how long can expanders stay in for? If, in under circumstances like this, they could just stay in, they could stay in for years if they
they're designed to stay in forever. I mean,
wow, okay. So there's
yeah,
really no harm in leaving your expanders in, aside from them not being as comfortable.
yeah, there's no real harm. I'm sure you can understand the manufacturers, the FDA, that has to think about the situation in which somebody just forgets to have it done, or
Right,
has
they can't have like a timer on them, like, oop, after a month they just.
yeah. And there's some implants that are designed to be able to expand. So the actual fact or the design in which that enables an expander to expand doesn't mean that there's a timer on or it needs to be removed. So there are implants that are intended to be left in place that you can adjust their size with certain techniques. But
yeah,
in general, and typically we like to do the exchange at around 3 to 6 months time from the initial implantation of the expander. And there's no problem if you wait longer. So women that say they have to have chemotherapy or have other medical problems, there's no problem to wait.
sure. Thank you for that. And we have another question. So someone wanting to change their implants to deep flap, she said it's a long story. Would you wait until after COVID-19 or start the process? I mean, it sounds like for the most part, unless there's a real urgent matter or if your life is at risk, there really is, you prefer that the patients hold on all reconstructive surgery, correct?
Yeah, exchanging implants to deep flaps is a pretty common procedure. It's probably one of my favorite things to do, for all them kinds of reasons.
Oh, to go from implant to deep flap?
Yeah, but that's not something that I would go planning on doing at this period. You can
Right.
thinking
Second of surgery. I mean, that's like hours of surgery, correct?
it's hours of surgery. It's a couple nights in the hospital.
Yep.
It's just being exposed to staff and and putting yourself with even your family that may come to visit you, that should come to visit you at the hospital. Why would you expose them to a place where there are other patients that have COVID and so on? So I would recommend postponing that. Definitely have patients that are scheduled to do that and just have to shift things back. Again, I'm sure you're doing it for a good reason and you can't wait to do it, but you should wait to do it at this point. There might be things that you can do to prime yourself for surgery, almost to your question earlier, Melissa, about how active one should be. With the deep flap, there's a component of trauma to a certain degree to the abdominal wall. For the most part, it's temporary, but the best physical condition you're in, obviously if you're smoking, stop smoking. If you're diabetic, control your blood sugar as best as you can. Don't contract other illnesses at this point that may throw you for a loop. And strengthen, like I said, strengthen your core, stretch, maybe even work on your upper body muscles to help you for after surgery, get up, move around. Some women I've seen don't have enough or may not have sufficient fatty tissue in the belly to be transferred. So, they might get a prescription from McDonald's to put on some weight.
Oh, so this is the quarantine diet for pre-deep flap surgery.
Unfortunately, that will go away after the post-quarantine and get back into shape.
Right, right, right. I know that would be a nice prescription. Please eat as many bagels as you possibly can before surgery. I'd like to see that script. um, Thank you for that answer. So we have another question, and I know that you might need a crystal ball for this one, but are prophylactic mastectomies and reconstruction not recommended during this time? And if not, when do you see them happening again?
Again, it's a little bit region dependent. I said earlier in the talk just now that the Plastic Surgery Society is essentially not recommending elective surgery at this point in time. Prophylactic mastectomy, while it's definitely not emergent, in most cases it's not urgent, and I wouldn't call it purely elective for obvious reasons, but I would say that, again, no crystal ball here, but I would say within 2-3 months we should be back to full steam on everything. I know it must it must be an adjustment for one's life, and I know women that have prophylactic mastectomies usually plan it to synchronize with other things that are going on with their lives, kids, and so on. So it's a tough one, but I would say put that on hold right now. Don't get
Right.
yourself sick otherwise. Doing a prophylactic mastectomy so you can live longer. Don't expose yourself to
Exactly. Exactly. There could be more risks involved by doing something like that now.
benefits.
Yep. We have another. Thank you, everyone. Such good questions. Keep them coming. We have another question. There are many implant types on the market, but when I went for a consultation for reconstruction, I only saw one type. Is there a specific type that is better for reconstruction as opposed to augmentation, or should I have options?
You should definitely have options. In the United States, there are essentially three manufacturers, or three main manufacturers of breast implants, both for augmentation purposes and for reconstructive purposes. There are a couple of other smaller, sort of more niche type implant manufacturers. I would say that frequently surgeons will have their one or two types that are their go-to for each situation, whether it be augmentation or reconstruction. And sometimes within those two scenarios, they may have a preference depending on the case that's presented to them. So there's a whole long discussion about breast implants, but in a nutshell, I'll say that you can categorize it in a couple of different ways. Number one, it is the content of the implant. So there's an outer shell that's always made out of silicone. There's a smooth type of outer shell, and there's a textured type of outer layer. Obviously, there's a textured subtype that has been removed from the market for other reasons that don't pertain to this talk right now. And then there are other types of textured implants that are still on the market. The content of the implant can either be silicone or saline. And then there are other characteristics: the volume, how large the implants are, the dimensions of the implants, how wide they are, and how much they project off of the chest wall. And then there are ones that are shaped in slightly different ways. Now, the inner component, the silicone component of the implants, are similar to the silicone that wraps the implants on the outside, but it differs in how the chains of silicone, the molecules of silicone, and the implants differ on how tightly they're knit between themselves. So implants that are very loose are the least what we call cohesive, and it's almost at the extreme similar to the saline implants, which is basically just salt water. So they may feel the softest, but they tend to ripple the most. On the other side of the spectrum, the implants that have the silicone molecules very tightly knit, they're called cohesive, that increased cohesivity. And then there are varying degrees in between. So the tightly knit ones are going to be the most firm, and they'll hold their shape the most, but they'll also feel the least natural. Each one of the manufacturers has that range of cohesivity and a whole range of the dimensions of the implants and what the surface is like. So surgeons tend to be very conservative people. Again, they want to do no harm, and they tend to stick to what they're used to. So if a surgeon is very comfortable with a certain line of implants, and it won't be one specific implant because everybody's circumstances, their body dimensions differ, their skin and soft tissue differ. So you have to have some kind of a selection. So the main manufacturers have most or all of the options within their armamentarium. So you can choose, if you're working with primarily one company of one manufacturer, then you'll have some choice within that. I'll maybe choose a certain implant for a certain situation, and then a different company that has slightly different properties from another manufacturer. Usually I'll tell the patients that, you know, there are several different manufacturers. We have access to all of them essentially, and I'll make the decision on what I'm going to use based on the person's characteristics, the patient's characteristics, and what we're trying to achieve with the reconstruction. And you know, I'll present them all the options, discuss the pros and cons of each, and we'll come together with a plan that will invoke during surgery. And there's always, I always request a little bit of leeway in making the decision that I feel like is best at the time of surgery, and that's sort of built into the consent form. So that's a long way to answer that question.
No, that's great. And I think probably the conclusion is that every surgeon is going to have a different grouping of implants that they work with, and they're going to probably try and work with the patient to determine what is the best fit for them, correct?
Now, yeah, but just looking at the question again, the specific question, there's a specific type that is better for reconstruction as opposed to augmentation. So I can't say that there's a better type or not. I would say that the main difference between reconstructing a breast from scratch versus augmenting one that exists is the amount of soft tissue that you have between the skin and the implant. So if there's a lot of soft tissue, or if there's a whole breast there and you just want to put an implant, then there are characteristics that of the implant that you choose that might be different if you know that the implant is going to go directly underneath the skin. But I can't say that one manufacturer is better than the other. But I can say within the spectrum of implants within each manufacturer, there is some that are more geared towards augmentation and some that are more geared towards reconstruction because of the soft tissue coverage.
That makes sense. That totally makes sense. Thank you for so thoroughly answering that question. And the next one actually is also on the same thought process as far as implants go, but this is more in relative to deep flap. So with deep flap, can you pick your shape or size like with implants?
Well, yes and no. The shape, well, I'll start with the size. That's a little bit easier. The size is primarily determined by the amount of tissue that exists in the lower abdomen. That specifically is the tissue that's going to be used for the deep flap. There are ways to augment that with natural tissue. There are ways to capture a little bit more fat in sort of each direction of the flap by extending, taking more fat from each direction of where the flap is being excised from. Mm-hmm. There are ways to combine flaps. You can extend the deep flap to take some of the flank tissue or the love handles area. There are ways to combine flaps from, say, the thigh and the belly. The deep flap is just taking fat and some skin from the thigh. Now, the amount of fat there will determine more or less the breast size. So one can, if you could pinch the area from more or less the belly button down to the groin area, each half can reconstruct each breast. You can combine two together to create one breast if you need that amount. And then that can be tailored to a certain extent. Sometimes we have women that have a lot of
Oh, I think his screen has frozen. We'll see if Dr. Bank comes back on. And if anyone has any other questions that they'd like to send in, we can certainly answer them. We still have some more time in which to do that. So we'll wait for him to tune back in, and let's see. Oh, I think he's gonna dial back in. Your questions have all been great. And, definitely if you have any thoughts relative, even if you're not currently going through treatment, if you're thinking about having reconstruction, any questions that you want to send in, we're totally happy to answer them here. We're just going to wait for Dr. Bank to join us again. And in the meantime, I just want to let you guys know that you can go to the Eris Foundation website anytime to learn about how they can work with you. You can apply for grants. They work with patients that have insurance, that don't have insurance. It's a really wonderful organization. So I encourage you to definitely check it out. Let's see, hopefully he'll be joining us soon, back again. And thank you for your patience. In the meantime, I'll just let you guys know that there you are. Oh, I was like, okay. I don't know how to answer. I'm not thank God you're back.
All right, so we were talking about can you choose the shape and size of a deep flap? So again, the amount of tissue that we can transfer that determines the size is the amount of tissue in the lower abdomen that can be augmented at the time of surgery with tissue fat from the surrounding area. We could actually do a hybrid procedure in which you do the deep flap and then put a small implant behind the flap. That's another way of getting additional volume, but then you're also using an implant, or that adds another sort of confounder to this. Mm-hmm. And another option is at a second stage, you can make the flap smaller, the breast smaller, or larger by putting an implant or transferring fat by liposuction and then fat injections into the tissue that was transferred. Okay, great. So I hope we answered that question about deep flap. The question was, can you pick your shape or size with like you can with implants? I didn't answer really to the shape. The shape is, be determined by the chest dimensions, by the skin envelope, and by how the surgeon just creates a breast mount from a triangle of fat, essentially, from the belly. So there's a little bit of technique involved as well. So excellent, good to know. I'm learning a lot here. I didn't know that about deep flap. Very, very good. Here's a good one for you. Should one have pre-filled expanders placed after a bilateral mastectomy to avoid hospital visits for fillings? That's a good question. If I'm presuming that lady is from a part of the country that they're still allowing this to be done right now. And yeah, that does make a certain amount of sense to avoid office visits, and sort of goes against sheltering in place. If it is safe to expand the expanders at the time of surgery, meaning if it doesn't stretch the skin too much that could cause wound healing issues, then you can get a head start by inflating the expanders and maybe the plastic surgeon will be willing to sort of push the envelope with the subsequent expanders in order to avoid unnecessary visits. Another option is to put in an implant that doesn't need expansion that might be a little bit smaller than the final implant that would be planned, but we do that a fair amount. We put an implant in that may be a little bit smaller than what we finally want to achieve, but we can avoid the expansion process with all the issues related to expansion, discomfort coming in for office visits, and so on.
Excellent. Well, thank you for answering all of those questions. Here's another one, and we actually have this answer from the Heiress Foundation. So I'll just read the question and the answer so everyone can be informed. So this patient said, I was scheduled for my reconstructive surgery, but it has been canceled due to the COVID-19. My husband works for a small company, and I am scared that he will lose his job and I will lose my insurance, which already approved the reconstructive surgery. What resources are there for women who are in my position but still want to have reconstructive surgery but lose their insurance because of COVID-19? And sadly, I think this is going to be a very common situation. So on behalf of the Heiress Foundation, they have informed us that there has been a lot of concern. We're hearing a lot about this, and that we wanted everyone to know that the Heiress Foundation is a nonprofit that helps women receive reconstructive surgery after mastectomy, and you can apply for a grant via their website, which is heirsfoundation.org. Okay, I just want everyone to know that. And you can contact them directly, and they're also going to post their website and a link to their contact information in the comments after this is all done. Dr. Bank, I really want to thank you so much for joining us today. I would like to also let everyone know that the Heiress Foundation will be hosting another Facebook Live next Thursday, April 9th at the same time, 2 o'clock Eastern Time. It will be with Dr. Rod Rorick, Clinical Professor of Plastic Surgery, Baylor College of Medicine. Also, Dr. Deborah Farr, Assistant Professor of Breast Surgical Oncology at UT Southwestern, Dallas. And Nicholas T. Haddock, MD, Associate Professor, Department of Plastic Surgery, University of Texas Southwestern. And the topic is Living with Breast Cancer During COVID-19, What You Need to Know About Your Course of Treatment and Options During this Certain Time. And the other thing I just wanted to make to really underscore is that, number one, you can apply for a grant with the Heiress Foundation. Number two, you can do it with or without insurance. And anyone that is interested in helping our community, donations to the Heiress Foundation, of course, are always welcome. So Dr. Bank, thank you again. It was so nice speaking with you. You've brought so much valuable insight, and you have such a nice calming demeanor. Really, really great to speak with you, and I'm glad that you were able to share your insight with our audience today.
Thank you, Melissa. It was great seeing you, even though it's remote.
Exactly. Hope to see you soon in real life. Take care.
You too. Stay healthy.
Thank you.